Good afternoon, my name is Jázmin Németh and my PhD thesis title is Oncocardiology. I'm a medical student at Semmelweis University. I'm at my 6th year, and I'm also an MD PhD student at the Institute of Pancreatic Diseases. Our vision is that the prognosis of patients with pancreatic cancer can be improved by addressing non-cancer related morbidity. And we would like to achieve this by providing further evidence-based recommendations on the management of cardiovascular comorbidities, which can help improve patients' prognosis. We have two ongoing projects. The first is investigating the prevalence of cardiovascular morbidity in pancreatic cancer, and the second one is investigating the prevalence and risk factors of cardiac cachexia in cancer patients. Both will be a systematic review and a meta-analysis. Let me introduce you my first topic, investigating the prevalence of cardiovascular morbidity in pancreatic cancer. Why is this topic important? Pancreatic cancer has a high incidence rate. To give an exact number, there were around 500,000 new cases of pancreatic cancer in 2020 worldwide. Studies suggest that patients with cancer, especially with pancreatic cancer, has a higher chance to develop cardiovascular morbidity. Moreover, studies also suggest that the cancer and the cardiovascular diseases or morbidity are not separate entities, but they are connected through common risk factors, pathological ways, and genetic predisposition also. Based on this information, it's clear that there's a need for preventive interventions to mitigate this risk and improve outcomes for pancreatic cancer patients. A specific clinical question is, what is the prevalence of cardiovascular comorbidities among patients with pancreatic cancer? And we would like to answer this question with a COCO-POP framework, where the condition is cardiovascular comorbidities, the context is pancreatic cancer, and the population will be adults. The clinical implication of this topic is that if we can identify and address cardiovascular comorbidities early, that may improve the prognosis of pancreatic cancer. And our hypothesis is that the prevalence of cardiovascular diseases or comorbidities is high among patients with pancreatic cancer. At the starting point of our selection, we had more than 40,000 articles. And after the duplicate removal, the title and abstract selection, and the full text selection, we get more than 150 articles. Plus, we found 44 new eligible articles by the reference chasers process. Regarding our first project progress, I would like to highlight that we have some results done, but some of the data's analysis is still in progress, and also the writing of the manuscript is in progress. We investigated two main outcomes. The first is the prevalence, and the second one is the incidence of cardiovascular diseases. As I mentioned, we have some finished analysis as the prevalence of all cardiovascular diseases together, and also the prevalence in subgroup, which was based on the applied therapy. Our ongoing analyses are the incidence of all cardiovascular diseases and also the incidence in subgroups based on the applied therapy and based on the patient's TNM stage. Here in this forest plot, I would like to present you the prevalence of abnormal blood pressure, which means mostly high blood pressure, but we had some hypertension cases also. I would like to highlight that this data is baseline data. So based on the result, we can see that 1 out of 3 patients experience abnormal blood pressure at diagnosis without any applied therapy. After the therapy, during the follow-up period, this proportion increases with 15%. We did the same calculation for the thrombotic event outcome. It's also baseline data, so we can say that 1 out of 10 patients experience thrombotic event like pulmonary embolism or deep vein thrombosis at diagnosis without any applied therapy. Also, I would like to mention that the heterogeneity is high in every case because of the different study design and the different population. We also investigated other types of cardiovascular diseases like arrhythmia, cardiac failure, stroke, ischemic heart disease. It is also baseline data, and we can see that the proportions are low. Here, I would like to present you some follow-up data. The median follow-up was below 1 year in every case. We investigated 3 subgroups based on the applied therapy. The first subgroup is patients who received gemcitabine-based therapy. The second group is patients who received immune therapy as a part of their therapy. And the third is who received tyrosine kinase inhibitors as a part of their therapy. We can see similar proportion in every group, even for abnormal blood pressure outcome and even for thrombotic event outcome. Based on this information, we can conclude that high blood pressure and thrombotic events are the most 2 prevalent cardiovascular events in pancreatic cancer. Regarding the implication of practice, we can say that we should be with increased awareness on thrombotic events because they may affect 1 out of 10 patients at baseline. And compared to blood pressure, which is checked routinely, mostly every day in hospitals, we don't have standard screening method for thrombotic events. Meanwhile, they can be asymptomatic cases. And also, we can say that the risk for other cardiovascular diseases at baseline seems low. The implication for research and for researchers that the mechanism of development of the cardiovascular diseases needs to be investigated deeply. Let me move forward to my second project, investigating the prevalence and risk factors of cardiac cachexia in cancer patients. Cancer is a leading cause of death worldwide. That's well known. There were nearly 10 million deaths in 2020. But what is rarely known that almost 80% of cancer patients suffer from a metabolic wasting syndrome known as cancer-induced cardiac cachexia. This syndrome is characterized by low left ventricle mass, which is associated with poor cardiac function, and that leads to an increased all-cause mortality in cancer patients. So our aim is to investigating the prevalence and risk factors of this syndrome. We have 2 different clinical questions. The first is, what is the prevalence? And the second one is, what are the risk factors for cardiac cachexia in cancer patients? For the first question, we would like to use a COCOPOP framework, and for the second one, a PFO, where the population is cancer patients. The factors will be any reported clinical biological factors that we will find, and the outcome is cardiac cachexia. And we have 2 different hypotheses for the 2 different questions. The first is that the prevalence of cardiac cachexia is high, and the second one is that there are specific risk factors that predispose cancer patients to developing cardiac cachexia. The implication of this topic is that identification of risk factors can influence decisions on cancer management and lead to avoidance highly cardiac toxic therapy in those with increased risk. And the second point is that if we identify modifiable risk factors for cardiac cachexia, we could try to prevent or slow its development. As a summary, I would like to mention that the planned submission date for our first project is January next year, and for the second one is May next year. I would like to thank you for your attention with a quote by Oscar Wilde: "Success is a science. If you have the conditions, you get the results." Thank you.
Thank you very much for your nice presentation. Just to make it clear, any cancer increases the risk of thrombotic event, and therefore anticoagulant therapy is a must in every cancer patient, even in pancreatic cancer. So I'm asking, and I wondered that in the studies you cited, the patients were on an anticoagulant therapy or not?
In some cases they were, in some cases they're not, but the results I show, these are all baseline. So before it, they didn't get any therapy, and not just therapy for their malignancies, but also they didn't get any anticoagulant therapy. So it was at diagnosis data.
Yeah, this was my question too, number one. And number two, do you know if the patients with cardiac problems, were they on any chemotherapeutic agents before or during when the cardiac problem occurred?
Regarding my first project?
Yes.
Yes, so in the subgroup analysis, we made subgroups based on the used treatment. We have some baseline data without any treatment. We have subgroups based on the TNM stage, so we are investigating a lot of risk factors and see if the proportion changes in the different groups or not.
Okay, all right, thank you. Any other questions?
Cardiac cachexia was a new term for me. Could you give me the definition? How can we define cardiac cachexia?
It is usually diagnosed based on ultrasound of the heart, and the wall thickness of the heart decreases in this syndrome, but it's not well defined yet how to diagnose it properly.
We have to exclude ischemic injury, hypertension, or?
I don't know so deeply this topic because we are at the beginning phase of it, so later maybe I can answer your question.
Thank you.
And one more question that I was surprised that you showed that there are more hypertensive patient in patient with pancreatic cancer, because in the clinical practice we saw the opposite. So due to the weight loss, the patient are usually so the blood pressure is usually decreasing, and patient have to quit their antihypertensive medication. So what do you think? What is the explanation for your finding?
Maybe in the hypertension cases, maybe mostly the common risk factors are behind that. So for example, risk factors for pancreatic cancer and also for hypertension are alcoholism and smoking, so maybe that is behind it. That's why they are existing at the same time, hypertension and the pancreatic cancer. Maybe later in the time, because it was baseline data, maybe later in the time it will change as the pancreatic cancer disease developing, maybe the hypertension will change.